You're giving your female patients testosterone?
I am.
Why are you giving them testosterone?
There is no...
Wow.
Not all men suffer from low testosterone. All women will go through menopause. From 1999 to 2020, menopause hormone therapy dropped almost 30%. So the Women's Health Initiative did more damage to women's health and hormones than any other single study in history. When someone is in perimenopause, should they wait? I hear a lot of people say, well, I want to wait. Wait for what? These things don't get better. I see a lot of providers putting patients on estrogen cream. We don't recommend it.
Every female listening to this podcast needs to be taking notes and considering this no matter where they are in their life cycle.
All women should have vaginal estrogen. And when they are entering perimenopause, vaginal estrogen with also testosterone will prevent vaginal atrophy. Women are not nearly as studied as they should be. It's embarrassing. It's actually embarrassing how little we know about women in relation to the science of this stuff. We cannot stop menopause or perimenopause, but we can get ahead of it. Just for the ladies out there listening, we're never going to treat menopause. It's happening.
Gabrielle, want to talk about estrogen. What are the most common kind of signs and symptoms that a woman is low on estrogen?
Number one, you won't believe this, and this might be very surprising, but when a woman is going through perimenopause, one of the first signs, she will be getting hot flashes. You've heard about hot flashes. Maybe you've even seen it. Have you ever seen a hot flash?
I have not.
We live in Texas.
Yes.
And it's very hot here. But before moving to Texas, I was in New York, and nobody was walking around with those handheld fans. Have you ever seen that?
I know the handheld
yes.
fans. Yes.
A sure sign and symptom that a woman is going through menopause. Okay, yeah, no, not funny, but true. One of the most common signs or even symptoms that a woman is low in estrogen, hot flashes. Also, joint pain, believe it or not, frozen shoulder.
Frozen shoulder?
Yes. And I learned this from Jocelyn, Dr. Jocelyn. She's an orthopedic surgeon who was recently on the show. And I didn't realize that when women are going through musculoskeletal pain, it's not just overtraining. Go figure.
Then why aren't more women on estrogen?
Well, I've got actually some numbers here for you. Are you ready for this?
I am.
Okay. From 1999 to 2020, menopause hormone therapy dropped almost 30%.
Why is that?
From the Women's Health Initiative. So it was 26.9% down to 4.7%.
Holy smokes.
Yes. So the Women's Health Initiative did more damage to women's health and hormones than probably any other single study in the history. You thought castrating men,
yes,
because you thought castrating men was bad. The Women's Health Initiative left 20 years of women from being treated for menopause. Meaning, you asked me what the signs and symptoms are. Hot flashes, brain fog, mood, poor sleep. All of these things can be contributed to low estrogen, not to mention change in a lipid profile. A woman's life who is going through symptoms of menopause is, again, it is so challenging. And I've seen it, and it really affects their lives.
Could you explain for the audience, the Women's Health Initiative, that was looking at the relationship between estrogen and cancer, if I remember correctly?
The Women's Health Initiative did a number of things. And the thing about the Women's Health Initiative is it used Prempro. It didn't use estradiol, which is what we now use. So Prempro, and then it used a synthetic progestin. They found that it increased the risk of cancer. And it was, for example, I'm looking at this here, higher risk of thromboembolism, stroke, and breast cancer. When that happened, they created a mass hysteria, and it really turned people away.
Everybody, so the baby got thrown out with the bathwater.
Everything got thrown out, which I think is devastating because we're seeing rates of osteoporosis and dementia, Alzheimer's dementia, at rates we haven't seen before. And it could have been prevented. The average age of enrollment, by the way, for the Women's Health Initiative was 63. That's 12 years past normal menopause. A woman typically begins perimenopause, and perimenopause is a big term. It's around menopause. A woman could have these symptoms for 10 years.
Wow.
Yeah. Really, really bad. But the thing is that the Women's Health Initiative equated this Prem-Pro and synthetic progestin with hormone replacement therapy. And it really turned people away.
So just to be clear for the audience, they should not use that as a reference point.
No. It dropped hormone replacement or menopause replacement therapy by 60%. It left millions of women undertreated.
So now that the audience has been educated and we're looking at this, what are some of the options? What are some of the delivery options for a woman who's considering going on estrogen?
Well, first of all, you don't do estrogen alone. You go to your provider, you get total estrogen, estradiol, progesterone, you get FSH and LH. Typically, those numbers will increase. They'll become high when you are in menopause. And around perimenopause, they'll be all over the place. Testosterone.
Testosterone?
Yeah, free testosterone.
Okay.
And sex hormone binding globulin. All of which are important. These hormones are so important for women, not just for brain and bone and heart health, and of course, lab values, but also vaginal estrogen. One of the things that I hear all the time in my clinic in Strong Medical is that sex becomes painful, or women are getting more UTIs. And then to top it off, they also can't train and are gaining weight.
Wow.
Yeah, it's interesting. Not all men will suffer from low testosterone. All women will go through menopause.
And yet, based on statistics, a smaller percentage of them is going to get treated than men, despite the fact that every woman listening to this podcast is either going to experience this or experiencing this now, or it's only a matter of time.
Yes, you would definitely go. If you are a woman, you will definitely go through menopause. And now we're seeing a resurgence of the conversation around menopause, which is so important, and perimenopause, because there's a lot of myths out there, and especially with the delivery system. For fertility and for pregnancy, so if a woman doesn't want to become pregnant, when she's young, she's typically put on birth control.
Yes.
Birth control will increase sex hormone binding globulin, which, think about it, hormones are like kids. So we have kids, both of us.
We do.
We do. And they can't go anywhere alone. Same with hormones. Hormones don't go anywhere alone. But when you increase sex hormone binding globulin, you make free hormones less available, which means from a young age, if women go on birth control, then she will likely require, for example, testosterone, to have a higher dose of testosterone than she would normally to get the same result.
Wow. I don't think that's discussed a lot.
No.
That's
what is definitely not discussed is that birth control, while important, that when you are taking an oral agent, it can affect the microbiome. Actually, we worked on a study with the legendary, I'll roll my eyes, Andy Galpin and Kristen Holmes. We just recently published a study on that. But
I saw that, yeah.
It affects the microbiome. Also will irreversibly increase sex hormone binding globulin. And again, someone will say, well, isn't preventing pregnancy important? Yes, but there are other ways to do it, like an IUD, which is the Mirena, a non-hormonal IUD. If a woman is entering perimenopause and is starting to get increased bleeding, an IUD can be very helpful if she doesn't want to take the pill, which personally I don't recommend. But again, you have to look at your blood work.
No, that's great. Hormone replacement therapy isn't an option for somebody. Are there any natural treatments that women can
menopause?
Do? For menopause?
We're never going to treat menopause. It's happening. You're never going to stop it. And I was recently at this amazing event. I went to a place called Newtopia, which actually I came over to your house to practice this talk. And it was this talk about conscious consumerism. One of the things that I kept seeing was take this for hormone balancing, this food for hormone balancing. That's the wrong message. Hormones being, quote, balanced, what does that even mean? The outcome that we're looking for probably in younger women is fertility. Polycystic ovarian syndrome is the number one cause of female infertility, which in a large part is related to the health of skeletal muscle. No amount of supplements is going to fix that, but a good diet and training regimen will help. Which, again, I know that we're talking about menopause and hormone replacement therapy. Estrogen and progesterone and testosterone are not used to treat body composition. for menopause, which people will say, I'm going through menopause, my body is changing. Estrogen should never be given alone. It should always be given with progesterone. Progesterone protects the uterus and the endometrium. Delivery systems for estrogen. Someone listening to this, our number one delivery system that we like in the clinic is an estrogen patch. Now, we live in Texas, which means it's hot. And if you are swimming a lot and going in the sauna, you might find it not great for you.
Then what do you do? Yeah. So if you're using an estradiol patch, you mentioned one mistake you avoid: swimming a lot.
A great question. Actually, I called Dr. Rachel Rubin. I don't know if you know Dr. Rachel Rubin. I do think she listens to this podcast. Rachel, I'm looking forward to seeing you at the North American Sexual Medicine meeting. But she said she'll use injections. And if someone cannot tolerate a patch, then potentially an estrogen injection. I think that it's a little volatile for people, but estrogen patch is the number one way to go. People ask me all the time what kind of protein powder I use. And in order for me to feel comfortable recommending a brand, I need to know it is clean and transparent. And that is one reason why I love one of the sponsors of the show, Peori, because every single batch of PW1 whey protein is, get this, third-party tested by the Clean Label Project for more than 200 harmful contaminants, including lead, heavy metals, and pesticides. It also has 21 grams of minimally processed, clean, high-quality whey protein powder from grass-fed cow's milk. No hormones, no GMOs, no pesticides. They were probably massaged. And also, it has 2.4 grams of leucine. PW1 whey protein is made from a few clean ingredients and comes in 2 delicious flavors. Bourbon vanilla, which it has real vanilla seeds from bourbon vanilla from Madagascar. PW1 dark chocolate with dark chocolate from raw organic cacao powder. Sign me up. Go and get 20% off site-wide by going to peori.com/Dr. Lyon and use the code Dr. Lyon at checkout for 20% off. That is peori.com/Dr. Lyon and use the code Dr. Lyon for 20% off.
So for the injections, how do you do that? Is that subcutaneous or intramuscular?
You can do all hormone sub-Q. Okay. And you could even mix it with your testosterone.
Whoa.
And also, guys, we're not giving medical advice, but we get so many questions on hormone replacement therapy or menopause replacement therapy. And because of all the myths out there, I thought we could break down a little bit of what we do in clinical practice.
No, but I want to go back to that and pump the brakes. You just said testosterone in terms of hormone replacement therapy when we're talking about the female patient.
Yeah.
You're giving your female patients testosterone?
I am.
Why are you giving them testosterone?
I don't want to say it's because it helps their husbands feel happier. I'm just kidding. I'm totally kidding, guys. Testosterone is really important for women, and it's important for sex drive. It's important for muscle mass. There is no FDA-approved testosterone for women, even though we can treat hypothyroidism with thyroid hormone. We can treat menopause with estrogen, estradiol, but there is no FDA-approved testosterone for women.
Do you think there's just such a stigma with testosterone in women, or just a lack of understanding?
All of it. I was shocked when I started treating women with testosterone. I was shocked at how little data is out there. And actually, we're working on a study at Baylor on safety profiles to really help move the needle for people. But in the US, it is not prescribed nearly as much as it should be. There is no FDA-approved indication. People typically give testosterone off-label for hyposexual desire disorder.
Is that the only reason?
I mean, not if you're in my clinic, but that is really one of the indications, which is unbelievable to me.
Yeah, that seems a little sexist, right? In terms of that's the only reason people are prescribing it to a female.
Well, the off-label indication, but when you think about it, testosterone is important not just for men, but also for women. And there are testosterone receptors everywhere. One of the things that I always hear from women is that they're afraid to go on testosterone because they're afraid of losing their hair, getting acne, voice changes, that their clitoris will grow. If you are being treated by a physician who is tracking your blood and you are given appropriate doses, not super physiological doses, you should not have a problem.
And then for their labs, are there any values that hard and fast, or are you just looking at the holistic patient kind of profile every time, or are there numbers that, kind of like the males have the 300 nanograms per deciliter? What does the female have?
And that's a really challenging question because we don't have great data for women. The typical dosing strategy is 1/10 a male dose.
Okay.
If a man gets 100 milligrams of testosterone, a woman should get 10, which that would be on the high end for us. The best delivery system for testosterone, in my opinion, is a sub-Q weekly or biweekly injection.
Which they could do also with their estrogen if they don't want to do the estradiol patch. So it's all at once.
They could. And you're probably thinking, what would you start with?
Yeah.
Are you wondering what you would start with?
I am wondering what you start with.
I would typically start a woman on testosterone before, if she is younger and she has not gone through menopause, and looking at her labs, she has low libido. Why is libido important to treat?
Mental health. There's a lot of other factors.
But think about it.
On, Gabrielle.
I know. Just setting you up there, that is also hilarious. Think about this. The relationships, having a good relationship with your spouse is everything. It means everything. You're not going to be able to live well if you are constantly at odds with your spouse. Now, I've been a doctor for well over a decade. There are two things that couples fight about: money and sex. I can't help someone's financial situation, but I definitely can help their sex life.
Okay.
And it is a couple's responsibility, a couple's disease. I don't want to say disease, but hyposexual desire disorder it has to last for at least 6 months. And it's not just a fluctuating libido, and it's not just in her head. And oftentimes it has to do with hormonal changes.
Wow. No, that's great. And I'm sure very helpful for a lot of the listeners. What about, so when a female goes on testosterone, are there any like body composition changes? Are there any other things? Because you mentioned some of the masculizing effects of testosterone. What can a female who wasn't on testosterone expect once she goes on testosterone? What
I have seen is that women's muscle mass can increase if they're training. You'll also see her recovery is better. For a woman going on testosterone, I think it's really important to manage expectations. When women come into our clinic and they say, I'm going through menopause, my body composition has totally changed. When they start estrogen, progesterone, and testosterone, we typically don't see a change in body composition if that's all you're doing. And I can't give you an answer as to why, but as opposed to, say, a male, we were talking about that other study, you put a man on testosterone.
Goes up, muscle goes up.
But also the dose is so much different. Mm. The dose is 1/10 a male dose. When she is training and her diet is together, we do not necessarily see a negative change in body composition through menopause. And that's probably one of the most common things that women will say. I'm going through menopause. Let's take away hot flashes. Hot flashes, brain fog. Those two, listen, we hear that all the time. But also women really struggle with body composition changes around this time. Yeah. And the question is it related to hormones? Probably. But once you replace those hormones and her symptoms are better, if she is not training, eating well, and drinking less, we won't necessarily see changes in body comp.
Yeah, so you got to do it. But I mean, it makes sense because, right, like estrogen is going to affect insulin sensitivity. Mm-hmm. So less estrogen, less insulin sensitive. So, I mean, it would make sense that you improve that, you can improve body composition. I know we're talking about menopause, but perimenopause, like, is there like fertility? Like, what's that look like if a woman still wants to conceive?
Are you guys planning on having more kids?
No, we are not.
This is a great question. A woman who is going through perimenopause, which perimenopause is that time around menopause can last 10 years. The average age of menopause is around 50, which is so disappointing. It's happening. And I do think, just for the ladies out there listening, we have to accept it. And it kind of sucks because with lower estrogen, our skin changes, our joints change, our hair changes. And how can we stop that from happening? Well, we cannot stop menopause or perimenopause, but we can get ahead of it. What do I mean by getting ahead of it? If a woman is having symptoms but still menstruating, let's say her periods are terrible and she's not sleeping, we would start with progesterone first for sleep. Micronized progesterone, and that is given orally. I see a lot of providers putting patients on estrogen cream. We don't recommend it. We recommend micronized progesterone. The absorption is better. Also functions as a GABA agonist, helps people sleep. There's also progesterone troches. And I'm going to give you another tip. Postpartum, some women that go through really bad postpartum depression, sometimes providers will give, say, just a shot of progesterone, 200 milligram shot.
And that can help
with postpartum depression.
Wow. And the cream, is that just an absorption?
Also the metabolism. Cream is interesting. It's really tough for people. Now, the delivery mechanisms for hormones, let's think about what they are. Injectable, topical, and oral. Injectable, there's a lot of ebbs and flows because you inject it, there's a peak and a trough. Topically, you have less ability to control the delivery system. Here's why. And I'm saying delivery system, that's not the right word. For example, an estrogen patch. And I've used estrogen patches. I switched from the Vival Dot to generic, and I looked at my numbers and my numbers didn't change. It was because my skin was not compatible with that patch versus a Vival Dot. And again, I have no relationship to these companies. The skin quality and the kind of skin you have
makes sense,
plays a role.
Yeah, if thicker skin or, for whatever reason. You mentioned those other delivery methods. When we were talking a little bit about testosterone, what about the nasal? Is there a nasal estrogen?
There is. I do not use a nasal estrogen. What a great question.
Why not?
I don't know. I don't know, because the patch works so well. I don't recommend estrogen cream because think about it. The patch exists. Have you ever seen an estrogen patch?
I don't think I've ever seen one in person. No.
The patch has the designated amount as opposed to the cream. The cream it's totally messy. You might do 2 pumps and maybe this time you got a bigger pump.
Yeah, I can see that.
But the absorption for estrogen cream, I'm not a fan. What I love estrogen cream for, and I think all women should have vaginal estrogen. And when they are entering perimenopause, vaginal estrogen with also testosterone and even DHEA in the cream will prevent vaginal atrophy and protect people from UTIs.
Wow. Is that compounded, that combination, or is there a product out there that already does that?
We typically use compounded, but every woman listening to this who's going through perimenopause or someone who is suffering from UTIs, number one, do not get constipated. Constipation increases your risk of a UTI. Believe it or not, it affects the anatomy. And number two, estrogen cream is really good for the flora.
Wow.
For the vaginal flora. Yeah.
Didn't know that.
Thanks to one of the sponsors, it has me asking, why go out when your pajamas feel better than most relationships? Cozy Earth's pajamas and blankets are so irresistibly soft and breathable, and of course stylish, you'll find yourself planning your evenings around them. After a long day of traffic, kids, stubbing your toe on the coffee table, I may or may not have done that this morning, slip into Cozy Earth's bamboo stretch knit pajamas. These lightweight, ultra soft pajamas are crafted from breathable, stretch knit bamboo viscose that sleeps noticeably cooler than cotton. They are perfect for keeping your temperature regulated. And if you thought it ends there, well, it doesn't. Sink into luxury with their bubble cuddle blanket. Its unique textured bubble design and plush faux fur, it's amazing, and it adds beauty to any room. So if you're not sold yet, let me get to the point. 100-night sleep trial, a 10-year warranty on blankets, lifetime guarantee on apparel. Man, it doesn't get better than that. That's right. Cozy Earth backs their comfort with promises that last. Head to cozyearth.com and use the code Dr. Lyon at checkout for up to 40% off your new favorite pajama set and blanket. And of course, if you get a post-purchase survey, tell them that you heard about it here. Thanks to one of the sponsors of the show, Bond Charge. Man, if you're a mom out there and you've been carrying the whole team, I got a different form of therapy for you, and that is red light therapy. And listen, good light impacts sleep, hormones, mood, and even your ability to recover and focus. Bond Charge has created science-backed tools to help me live in better alignment with my circadian biology. Artificial light is overloading us. They have blue light blocking glasses that are a staple in our house. They have red light. They have red light bulbs. They also have infrared PMF mats to help chill my body, relax my muscles, and support full body recovery. If you've never tried red light therapy, this is the time to do it. They have some of the best devices that I've ever seen. Great for skin, mitochondrial health, and overall resilience. If you care about your skin, if you care about your sleep, if you care about your body, and want to try something new, check out bondcharge.com/Dr. Lyon. Use the code Dr. Lyon to get 15% off your entire order. Simple, proven, designed to support your biology.
You mentioned DHEA, and so kind of as we talked about with males, are there any supplements or any things like that are out there for estrogen production or things that you put females on that you'd recommend?
DHEA is one of the agents that we use.
Okay.
Believe it or not, because I kind of poo-pooed any kind of oral hormone balancing, but DHEA definitely can be used. And we use anywhere from 5 to 10 milligrams, depending. You could even go to 20. Sometimes women will get some acne from it, but there is potential evidence for it to be supportive, DHEA use in women. Also, we were talking about hyposexual desire disorder and the genitourinary symptoms of menopause. There is an FDA-approved vaginal DHEA insert, which it's 6.5 milligrams, and it is called Intrarosa. And it's indicated for postmenopausal women with painful sex and vulvovaginal atrophy.
The DHEA versus just the estrogen, because my understanding, the DHEA, it can go to estrogen or testosterone. So is that just kind of given the body, for lack of a better word, like the substrate to produce what it needs to produce in the ratio that's needed?
But also keep in mind, if a woman is in menopause, DHEA is separate, and that's one of the blood markers that we measure. I don't know if I mentioned that earlier. We do measure DHEA. DHEA can be important for inflammation as well.
Wow.
If a woman is on estrogen, progesterone, testosterone, and you measure her DHEA and it's low, definitely supplement it. But I also want to be clear in terms of expectation. A woman who is in menopause isn't going to take DHEA and all of a sudden feel better as if she is on menopause replacement therapy.
DHEA is always used in conjunction. It's never like a monotherapy.
It can be.
Okay.
It can be when you're young. But again,
define
hormones,
young.
That's right. That's such a good, tricky question here. When you are young and you are making hormones, you have a lot of flexibility. As you get into perimenopause, you'll see that sometimes cycles become irregular. You will see sleep gets disturbed. But if you measure your blood work, you might go to the doctor and the doctor might say you're fine. And you go, you know what, doc? I'm just having brain fog. I'm not feeling well. And you have to be able to treat symptoms. And one of the ways and there's various ways to measure, you can do it very complicated. There are month tests. Can you imagine testing urine or blood levels for a month to see what your markers are?
That's not fun.
Not fun. But I think that figuring out how you feel as a woman and understanding that there's a cyclical nature and starting, I think, progesterone, which is protective, uterine protective, can be very helpful. And our starting dose for women, again, we use a micronized progesterone. It could be 100 to 200 milligrams. Women with endometriosis seem to respond really well with micronized progesterone. And it's a great place to start, very safe. Again, right now we have a landscape of coming out of being afraid for the last 20 years.
Yes. And so in that same vein, I have a female friend who went to their physician and asked about these things and were immediately shut down. Immediately check, you're fine. Everything's within normative value. So I want to ask you, how do you recommend that patient who maybe went out and asked their provider about these things we're talking about, and they get shut down immediately, to tactically push back? And then is there a point or cutoff point you would recommend that they go find a new provider?
Probably immediately.
Okay.
I mean, because part of being a physician, and you know this, you don't see patients, but you have clients, as our ranger and dietitian and, taking care of high performance individuals, it's a team sport. If someone is coming in and saying, hey, I'm going to give you an example. Are you ready for this?
Yes.
I know a patient, she's postmenopausal, and she missed the quote window of opportunity for menopause treatment. There is information out there that once you are 10 years past menopause, that you cannot be treated with hormones. Well, think about all the women that missed.
That doesn't seem right.
Right. Part of it was the increase in coagulability with an oral agent. There's concerns about blood clots, strokes, but we have to recognize that, number one, women are not nearly as studied as they should be. It's embarrassing.
Yes.
When you go back and you look, it's actually embarrassing how little we know about women in relation to the science of this stuff. And number two, there is a lot of information that's taking a long time to get out. For example, oral birth control might increase coagulability, which is the clotting in your blood, but there's very little evidence that an estrogen patch, because of the delivery method, increases coagulability. Or again, people are concerned about DVT. So back to the story, this woman who's postmenopausal said, I chew a lot of nicotine gum. And the provider said, well, we're not going to put you on estrogen because of it. But the reality is we have to re-educate and understand I appreciate the safety of that, but we have to recognize that the information out there is not the same. It's not just about estradiol. It's also about the delivery mechanism. From a safety standpoint, estrogen, especially delivered in a patch, is very, very safe.
So with that, and kind of back to that case, a woman goes into the physician, she's experiencing this. What should she say? I mean, is there kind of a, for lack of a better word, a script or words she should say? And then you're saying, if that physician immediately like shuts you down and they're like, you know what, you're fine, you're not in a disease state.
Yeah.
You would say immediately go and look and try to find another provider.
I would. I believe that there's two ways to looking at preventative care and medicine. Again, there's probably a lot more than two ways, but there is the physician that is going to treat you for a cold, treat you for things, you're coming in, you're sick, I'm treating you.
Yeah.
And then there are the physicians that are thinking long-term. For example, we know menopause is coming. Hot flashes are real. It's not just hot flashes. It's osteoporosis. If someone falls and breaks a hip, it's not just, I have brain fog now. We're talking about Alzheimer's later. If you treat these things early with velocity, then your chances of living a long, healthy life and one that is enjoyable increases. As opposed to, you know what, you're not there yet. Your FSH and LH are not really high. Your estrogen is not zero. Why would you wait?
No, that makes perfect sense. And so is there a resource or kind of a place for women interested in this, what we're talking about, to find these more forward-thinking, preventative physicians that are out there?
Well, we treat it in our clinic, Strong Medical, but also you can look at, there's various organizations of physicians that are trained in menopause treatment. Again, there's the Endocrine Society, ACOG, NAMS, NAMS. I don't know who came up with all these acronyms, but yes. And I will say that people will go to non-hormonal medications. If someone says, well, you know what, I'm having hot flashes, someone might say, okay, well, let's put you on an SSRI. Well, or I'm depressed, let's put you on an SSRI. As opposed to, just like with men, if a man is depressed, well, we check his testosterone, or we should be. We should do the same for women, for sure.
Wow, I didn't even think about that. So that is really a great point to highlight, is some of these psychological issues that we may see that we're going to psychotropics could actually be fixed via hormone therapy.
Totally. And the other thing is, the next question is, when someone is in perimenopause, should they wait? I hear a lot of people say, well, I want to wait. Wait for what? And I don't mean to be negative.
It's not getting better.
But these things don't get better. You are not, I mean, could you suffer and go through hot flashes? Totally could do that. Will your brain fog stabilize? Maybe. The next question is, how are we also going to protect your bone? Do you need to train? Yes. Could you just take hormones and be better? No, you have to have these lifestyle factors in place. But the conversation needs to change a bit in the way that certain things are not going to get better. You are going to have less estrogen. You will have typically less progesterone. Your testosterone may go down. These are not things that through a flower or an herbal tincture or psychotherapy is going to change. It's that time again, man flu season. Wait, no, just kidding. All flu season. And needed immune support, it's an easy to take, delicious elderberry powder, and it's designed to support optimal immune health for the whole family. Man, when I was pregnant, I could not figure out what to take. And most immune support products aren't designed for all ages and all stages. Needed immune support is safe and effective for the whole family. Kids, pregnant moms, nursing mothers. It has zinc, elderberry, prebiotics, and postbiotics in optimal forms, and of course, dosages that are clinically studied, safe, and effective. It is formulated by a group of pediatric practitioners and moms, one serving daily for optimal immune support all year round. And let's face it, there's a lot of stuff on the market, and it's important to get clean products. Go to thisisneeded.com and use the code Dr. Lyon for 20% off your first order. That's thisisneeded.com.
This is really exciting and eye-opening because basically every female listening to this podcast needs to be taking notes and considering this no matter where they are in their life cycle, right? Whether it's preemptive or they're already experiencing this and need to get treatment right away.
Yes. And estrogen therapy is very safe. It is approved MHT, so menopause hormone therapy, considerably lowers the risk of hip fractures.
That's huge.
Hip fractures. Vertebral.
Which can be a death sentence. I mean, people don't understand. A hip fracture when you're 70 can be fatal.
Yes. Cardiovascular protection. Again, it's not the only treatment.
Right.
We can't say, well, I'm going to give you estrogen and it's going to prevent your cardiovascular disease.
No, but it's going to raise HDL,
That's
probably
right.
lower triglycerides.
Yep.
Yeah.
And also transdermal estrogen, micronized progesterone, and then the Mirena, it does not appear to increase the risk of DVT, which again, that is really one of the
deep
major
vein thrombosis.
Which is one of the reasons why people have really turned away from it. Transdermal estrogen, micronized progesterone, also it appears to be favorable in blood pressure.
Wow.
Where that's something that we didn't talk about. Testosterone can increase blood pressure. That is, again, something that we didn't mention. But I also looked up some numbers, and recent reports indicate that only 1.8% of women over 40 are using hormone therapy for menopause, even though 100% of women go through menopause.
There is like 98.2% of the population out there that needs to be on it who are not getting it.
And it becomes a really important conversation. Estrogen and progesterone, people are much more open to it now, and that's FDA approved. But testosterone is not. I just want to put that out there. I think that is fascinating and important to understand.
Yes. No, especially given all the benefits that you just highlighted. Why wouldn't it be FDA approved? And I wonder if that's coming with enough people using it off-label, right? Or this surge.
And then the other thing is imaging. And we didn't really talk about this. There is also a lot of information out there where people are afraid to get mammograms at 40. You should. There is no reason why you wouldn't go and get a mammogram. People are afraid of radiation. And I would say, listen, you've got to put these screening pieces in place. But what about the woman that cannot use hormone replacement therapy?
Yeah, what does she do?
Well, this is where a real conversation comes in with both the oncologist and the menopause expert. Because not all cancers or breast cancers or uterine cancers, whatever kind of cancer, necessarily would exclude you from taking hormone replacement therapy. Now, when you take a look at men, there are men that have prostate cancer that are treated with testosterone.
Yeah, that's
and
wild.
They do better. You have to, it's not throwing out the baby with the bathwater.
Yeah. Separating for taking each of those instances separately and looking at it. No, I mean, this is all great information. And I think for that female looking to, consider hormone replacement therapy or have that conversation, you've laid out a great roadmap into how they should approach that. And then most importantly, if their physician's not willing to have that conversation with them, to find a new physician.
I agree with that. Let's talk about how often individuals should get blood work.
Yes.
And listen, depending on where you are in your cycle, you can take it on day 21, etc. But let's think about how often a woman should be getting her blood work who is going through menopause treatment or even perimenopause. At baseline, 4 to 6 weeks after she begins a therapy. And then I would do it again another 3 to 4 months to make sure that she's regulated. Do we regulate based on blood work numbers? Not necessarily. She should have symptom control, vasomotor symptoms. She should be sleeping better. She should be feeling better from a mood perspective. And also, we want to see, again, this isn't direct treatment, but if her cholesterol numbers really tank during menopause, which is what we see perimenopause, menopause, we should see some improvement in that if she's being treated. And then, of course, it's not always hormones. You have to look at thyroid as well, meaning it's not always sex hormones. You have to look at everything.
So so a thyroid panel would be part of
always
that. Always. It's going to go with it.
Let's talk about how a woman can take testosterone.
How can a woman?
A woman can take...
Besides the mix and okay.
How a woman can take testosterone. A woman can take intranasal testosterone.
All right.
A woman can take testosterone gel or cream. Very messy. She can also take testosterone intramuscular in her shoulder or butt. She can also take it sub-Q.
I imagine the cases are kind of similar, like the male, in that you're going to see more of the peaks and troughs intramuscular or no?
Yeah. It depends on if a woman is, and I think that eventually women will be able to take it orally through the lymphatic system, which would be, so Kaisertrex is used for males, but I do think that eventually they will be using it for women. Women do the best clinically that I have seen with sub-Q doses of testosterone. And we start anywhere from 5 milligrams a week. It should be typically 1/10 of the dose of a male. 5 milligrams is often too low for women to feel better with libido. Upwards of 10 milligrams a week seems to be a sweet spot for women.
When we're talking about this, just to clarify, would testosterone just be the only therapy you would do, or is this always in conjunction with estrogen?
Actually, sometimes.
Oh, wow.
Sometimes it depends on the woman. Some women, you put on estrogen, they don't feel great. Progesterone is great for sleep, and some women do great on progesterone, but nearly all the women that I have treated do very well on a low dose testosterone therapy.
That's surprising, I think, because what percentage, I don't know if we have that, of like women who are, I mean, we talked very low, the low percentage of women taking estrogen. What percentage probably are taking testosterone, even below that? So we talked a lot about estrogen replacement therapy, hormone replacement therapy with these females. What are some of the risks associated, or are there any?
What's that saying? There's no free lunch. I mean, there might be. But when it comes to hormone replacement therapy, and listen, everything has a risk, and we have to balance the risks and benefits, whether it's tirzepatide, Ozempic, all of the agents, everything has a risk. Estrogen, progesterone, testosterone, the risk isn't the same for everybody. Would I say that it is of benefit? I would say yes, but it's definitely case by case basis. Can there be an increased risk in breast cancer or uterine cancer, depending? It depends on your genetics, with your lifestyle, with these agents. A good provider is going to sit down and go through everything with you so that you can make an informed decision. But we can mitigate certain risks that we know. So for example, if we know that an oral agent is going to increase the risk of a coagulopathy or some kind of clotting, then we would use transdermal instead of oral.
Gotcha. So looking at not only the substance, but also the administration, the route of delivery, all like that.
And then getting a uterine ultrasound, getting a mammogram routinely, getting a Prenovo or a full body MRI scan, also doing the early detection cancer screenings. There are all things that we can do because ultimately the idea is how do we live as better, stronger humans?
That is awesome.
Right?
Yes. I love it.
Again, hopefully this was valuable and helpful for people in understanding what kind of blood to get, how the deliveries are done, why it's important. And again, this is just the beginning of the conversation.
Yes.
So thank you so much, Nick.
No, thank you.